Hey everyone, I am Nick Berry. I'm a senior statistical scientist at Berry Consultants, and I'm also a facts developer. Is a huge part of my job. So I'm going to be doing the webinar today about longitudinal models in facts specifically. I have a lot of material to cover, but it's also like 10% of what I wanted to talk about. So there's a ton of stuff that we could talk about. I think I could do an 8-hour webinar with some prep just on longitudinal models, describing the models, stuff like that. So maybe this is going to be one of many, but I think this should hopefully give like an overview of what you can gain from longitudinal models. It's not going to be hyper specific to this longitudinal model in this case. It's not going to be this is what this parameter means in the longitudinal model, but I think it's about efficiency and it's about what you can gain from longitudinal models. And maybe we'll do a deep dive into some and look at some more details about specific models in other webinars. So kind of keep that in mind that this is going to be a lot to talk about, but it's also that it leaves a lot out. So set up my screen. Let me try to set up a region where I want to share. Okay, so hopefully you can see that set of slides. Might be adjusting stuff as I go a little, so apologies for that. Okay. The entire webinar, this entire call, I'm going to focus on an example just to ground us in something so that we're all speaking the same language and working with the same trial. I kind of tossed around a few different ideas and landed on a particular one that I think is interesting. You may be familiar with it. It's the Bayesian 2401 trial, or the drug that became known as lecanemab. It's an Alzheimer's drug. So we're going to design, I'm going to, just throw it up, but generally we're going to design a phase 2 Alzheimer's trial. The endpoint is going to be ADCOMs, common like degenerative neurological disease endpoint. So we're going to measure the change from baseline in ADCOMs at 1 year, at 52 weeks. What this looks like is patients start in the trial with, fairly stable. This is mild cognitive impairment. They come into the trial with an ADCOM score that's low. Low is good. And as they progress, as their disease gets worse, they have, develop more neurological impairment and their ADCOM score goes up, which would be a change from baseline in ADCOMs at 52 weeks. So going up is worse. It means you're degenerating in some one of the many tests that go into ADCOMs. Okay. So when I talk about an endpoint like, oh, this patient observed a 0.1, that means they got worse by 0.1 relative to their baseline visit. And not getting worse is actually good. So if you're a 0, that's great in this trial. It means you didn't get worse in cognitive impairment throughout your 1 year of follow-up in this trial. The treatment arms. So I'm kind of following the phase 2 trial that was actually run for lecanemab. I'm loosely following it, I'll say, but I'm using specific aspects of it to sort of give us a working trial. The dosing in that trial had 3 different magnitudes of dose: 2.5 milligrams per kilogram, 5 and 10 milligrams per kilogram. And then they also varied the frequency of the dosing. You could either get that dose biweekly or monthly, except for the 2.5 kilogram milligram per kilogram monthly. That's not one of the doses. So all in all, there's 5 active doses in a control. Okay, so that's what we're working with. This phase 2, we want to know the dose, right? That's the goal, is to find the dose that we want to run a phase 3 trial in later. Going into the trial, and in my, my catbird seat where I get to sit and look at what happened, I know and I expect that control patients are going to get worse by about 0.1 on this ADCOM scale. That's past experience. That's looking at the actual phase 2 trial results. But patients are going to get worse on control. They're going to degenerate a little bit. So 0.1 is our expectation for that. This trial, and for the real trial and the one we're designing, they targeted like a 25% improvement. So if we could reduce the degeneration by 25%, that would be great. That's a goal for us, and I'm going to call that the clinically significant difference. I just did 0.025, an absolute. If we improve by 0.025, we don't change as much as control by 0.025. That's great. And other technical things, I'm going to assume an accrual rate of 3 patients per month, and this is going to be an adaptive trial. 13 interim analyses starting really early in the trial. And I'm going to allow early stopping for success and futility at each of those interims with a maximum sample size of 800. That should probably be on here somewhere. So 800 patients max, lots of interim analysis, and we want to stop if we all have a clinically significant benefit that's high enough. Okay. This is close to the lecanemab trial. It's not exact. We didn't use response adaptive randomization. I'm not going to do fancy dose response modeling, stuff like that. Okay, so if you go to the paper and you're reading about it, you're going to notice that there's differences. I simplified it for the purposes of this. I didn't have to. You could do all this stuff in facts, but it was beyond the scope of this call. Okay, so let's get out of the PowerPoint presentation and let me jump to facts and just show you what I've set up. I do have a ton of material, so I like to click through facts and actually set things up with you. But in this case, I in the interest of time, I sort of, I'm cheating a little bit. So I've already filled these things out, and I'll just walk you through what it is. So on the front page, I've set up 800 patients with a 52-week endpoint. That's really all I did here. I said lower response is improvement because we don't want people to have high changes here. I've set up a 2D dosing model, which I didn't have to do, but I did. And so I can show you the grid that comes out of this. You can see there's magnitude of doses and then frequency of getting those doses. And I assign some values to those, but we're not going to actually use the dose response model. So you could just think of this as a control and 5 separate doses that show up like this, which is exactly what I said before. I've created scenarios, a variety of efficacy scenarios, starting with the null scenario where all arms, the average worsening for patients is 0.1 in ADCOMs. And I have a standard deviation of 0.18. That's the variability of a patient's change from baseline ADCOM score at 1 year. That's pulled mostly from that lecanemab phase 2 study. So we have a little bit of a help there. And then I varied the effects. So I have mild benefit, I have pretty solid benefit, and then I have a really strong, patients only get worse by 0.04 on all the treatments, but to get worse by 0.1 on control. And then I have a non-linear case, a linear case. And then I made one that looked like the lecanemab final output. Okay, so the point is that I want to assess this trial across a wide range of responses. And so I did some bad, like I don't expect to have high power in this situation. I don't expect to have high power in this situation, but I do expect to have high power in some like this, strong effects on all arms. So I want some low power, some high power, some easy, some hard, and I spanned the range of it along with a scenario to test type 1 error. Okay, I've set up my accrual rate to be 3 patients per month. It's going to randomly simulate patient accrual. So sometimes we'll have 1, sometimes we'll have 6, right? This is a random process, but the average number of patients per month, or per week, patients per week is 3. No dropouts because I want to keep it simple. I created a quantity here. So the measure that we're going to use for the entire trial, the only decision-making we're going to do is based on this quantity. It's the probability that we have a clinically significant benefit. Probability that the treatment is better than control by 0.025 on that change from baseline and ADCOM scale. All right, so I could delete all the other QOIs here and really just worry about what's the probability that the best treatment is clinically significantly better than control. So that's the measure I'm going to use throughout FACS. And that's a default QOI. All I had to do was tell it what the clinically significant difference was. Oops. And it showed me the calculation. It knows the lower is better. It knows all of those things. So it creates that quantity for me. Okay, so while I'm talking about decisions and probabilities, you can just keep the CSD in your mind a little bit. And then the design. I'm going to keep it simple, except for the longitudinal model eventually, because that's what we're here to talk about. So keeping it simple largely means that the dose response model, so borrowing of estimates of how well a dose is doing across the doses, I'm not going to do. The actual trial used this 2D normal dynamic linear model. So it's smoothed across the dose magnitudes. It also smoothed across the frequencies and borrowed in each of those directions to create sort of a smooth grid over the set of active doses. That's advanced. It would improve a lot of things in the trial. Some of the, maybe type 1 error rates, some of the dose selection stuff would be, was facilitated by that model, but we're not doing it. We're staying with the independent arms. So if you look at this equation that pops up, that just means every dose has its own normal prior. Every dose mean has its own normal prior. And then patients are assumed to be normally distributed around their dose mean with a shared variance parameter sigma squared. Okay, so really as simple as we can get. We expect to just estimate a dose near its observed effect. The priors I set are non-informative on this scale where we expect 0.1 to be the max a patient's going to change. So I set a mean of 0 and a standard deviation of 1. So we should only be about 0.1 to 0.2 standard deviations away from my prior mean, worst case. And then I set the variance parameter, the sigma squared. I know that I'm simulating a 0.18 as the mean, as the actual endpoint variance, but I didn't know that in advance probably. So I specified a 0.2 as my expectation for the patient level endpoint variance, and I'm only setting a weight of 1 patient for that. Okay, so that's set up. All my arms are estimated independently. The simplest dose response model you could do, it's just there is no dose response model. Just estimate everything using only its own data. We don't have dropouts, so I didn't even address that bottom box here. Okay, so simple, naive dose response model. I am doing fixed allocation. So, no RAR, no arm dropping, none of that. Don't worry about it. The interims, I have set up 13 of them. So we're triggering an interim analysis at 200 subjects enrolled, and then every 50 patients after that. This is what the actual trial did, the phase 2 trial. So that's what I did. The 200 patient interim is early, right? This is 1/4 of the total number randomized, and you'll see, but there's not very many patients complete at the time of this first interim. So we'll keep that in mind, that we are doing early interim analyses. And then success futility, I modified the rules a little bit from the original phase 2 trial, just to get sort of things to match up how I wanted. So we are going to stop for early success and we are going to stop for early futility. based on that probability of clinically significant difference. If it's too low for all of the doses, if all the doses have less than 10% chance of being clinically significantly beneficial, we're going to stop. And if any dose has greater than 98.8% probability of clinically significant benefit, we're going to stop for success in that case. And I tuned this so it gave me the type 1 error that I want. We'll talk about that later. So that 98.8% does that. And then if we do get to 800, we really want the clinically significant benefit to be greater than 0.9. So if we stop early, we want a strong signal. And if we get to the final, we have full follow-up of all patients, then I'm okay with a 90% probability of clinically significant benefit. These, again, they sort of mirror the lecanemab study, but they're off by, you know, the magnitude of the threshold. Okay, so that's the simple trial. And I can simulate that. I cheated. I've already simulated it. And we can look at the operating characteristics here. I'm going to go back. So power, like I said, we have a null case, and the type 1 error is about 0.08 in this case, where we're phase 2, we have 5 doses, 14 interims. We knew it was not going to be, you know, 0.025 control. That's fine. We want to find the best dose. That's the goal of this trial. So we do have inflated type 1 error, but we're doing a good exploration of our active arms, and that's great. We have anywhere from, you know, 28% power to 92% power. That's the proportion of overall success column is what I'm looking at. So we have sort of a wide range of operating characteristics here. To go back to this, oh, I should have showed that, but okay. The summary. So I clicked through those trials and looked around. And maybe I can do that real quick. I can go, for example, let's just go to this. I'll open up some simulation results, and maybe the first trial, I'll go to the week's results, and I want to look at observed. Okay, so this is showing one simulated trial, and it's showing the 5 interims and then the final analysis because it stopped at the 5th interim. Okay, so but that's not what I want to show. I want to show you the first line here. This is the first interim analysis, and it's reporting the number of patients complete on every arm. We have 200 enrolled at the first interim, so 33 or 34 per arm, but we have 6 patients complete on every arm, not very many, right? So we do not have a lot of data to make decisions at this point. And it's very unlikely that we're going to be able to claim something's beneficial at the first interim. That's fine. As we go forward, we get to 14 to 15 per arm, 23, 31. And at these points, you know, with the 4th interim, if we have a large effect, we could presumably stop with 31 patients per arm if we see, you know, 50, 60% improvement in that change in ADCOMs. It's possible to study. Okay, so that's one thing that I wanted to draw your attention to, is that we're doing early interims, and that leads to not a ton of data available at those interims. At the 4th interim, we have 350 subjects enrolled. That's about 32 to 33 per arm, yes. The standard error, the expected standard error in that naive dose response model that I have that just independently estimates every arm, is sigma over the square root of n, right? 0.032 is what that comes out to be. So I'm going to ground you in that 0.032, and I'm going to talk about that a lot because this is like a benchmark that we're going to use. This is at the 4th interim analysis. The standard deviation of our treatment effect is about 0.032. You can translate this to the width of the credible interval around the mean response for an arm, if you want. So, you know, small credible intervals are good. That's efficiency. That's precision. We like having small credible intervals when they're, you know, doing the correct calculations and have good coverage. Okay, so 0.032. That's using just the final data at the fourth interim analysis. The title of this call is Longitudinal Models. So you can see where this is going, is that I only used complete patients in this. But we can do better than that. So in this trial, they measured ADCOMs at 3, 6, and 9 months as well. Okay. The 3, 6, and 9-month data can be used to improve our estimate of what's happening at 12 months. That's the whole goal of this. We still want to make decisions based on 12-month ADCOM changes, but we want to leverage all the data we have. There's this, statistical anathema, essentially. You never throw away data, right? Use the data you have. And that's the goal, is to use all the data we have. So let's set it up. Let's talk about what we're going to do, I guess. There's a common misconception, and it is kind of not obvious, but what does FACS even do for longitudinal modeling? Because there's two types of these that live out in the world. FACS does longitudinal modeling, incorporates longitudinal data through multiple imputation. It's the only way it does that right now. So when we talk about improving estimates using early information, that's done through multiple imputation of the final response given early data. Okay, so I'm going to try to use the term multiple imputation really often instead of longitudinal models, which can be kind of ambiguous if you're familiar with longitudinal models being things like MMRMs or these disease progression models that sort of parametrically model a patient's route throughout their follow-up. So that's not what we're doing. We don't have an MMRM. There's no patient estimated slope in these models. We would love to have this. It's on the list. It's just not there right now. So kind of keep that in mind, that while I'm talking about using longitudinal data, I'm talking about multiply imputing the final data point as precisely as we can given early data. Multiple imputation works seamlessly with the Bayesian model. So the key to this is that when you're making decisions based on longitudinal data, it's done using the Bayesian model that's run in FACS, right? At every interim, at every final, you get one Bayesian model run in FACS, and that's what it does. It incorporates longitudinal data. It's integrating over likely values of final responses for subjects who have not yet observed their final response. Okay, so the multiple imputation is paired with the Bayesian model inextricably. It can't be separated. They work together. And it also works with the dose response model. So when you're imputing patients, that's updating the dose response model. It's co-estimating the longitudinal model. Those things get mixed together. It's sort of a nice feature of FACS that they're modular. They mix together, but you can mix any type of dose response model with any type of longitudinal model, and they mesh really nicely. Okay. Then another, result, I guess, of us being a multiple imputation model is that it really helps when we have patients that don't have final responses. When we have patients that have only gotten to 6 months but don't have 12 months, we're going to get efficiencies in the longitudinal model, the imputation model. It's going to happen. If you're at the final analysis, so in our trial, if we've enrolled 800 patients and collected a year of follow-up on all of them, the longitudinal model is going to do nothing because there's nothing to impute, right? So the imputation model is very good at providing efficiency at interims, but it's not actually going to give you efficiencies if you just enroll to the end and do a t-test, whatever you do. Okay. So that's something to keep in mind as you're toying with longitudinal models and you're trying to figure them out, is that you have to have missing data in order for them to provide benefit. That can be in the form of dropouts. So even if you just do one analysis at the very end, if you have 20% dropouts in your study, but they drop out after collecting intermediate data, you can still get benefit. But you have to have either dropouts providing missingness or patients that have not yet had time to observe their final analysis. Okay. Let's expand on this a little. So multiple imputation models. What does that mean? Throughout, at some interim analysis, we're going to talk about the fourth interim analysis when there's 350 total patients enrolled in the study. There are patients that fall into certain different bins. Some of the patients we've enrolled have complete data. They've been in the trial for more than a year. They observed values at 3-month, 6-month, 9-month, and 12-month visits, say. Those patients don't need to be imputed, right? They have complete data. They don't need to be updated. What they do, and what's the valuable thing about these patients is that this is how we learn the multiple imputation model. This is how we learn how to impute future, other patients that do have missingness, because these patients have full 3-month, 6-month, 9-month, and 12-month data. I can estimate the link between visit 1 and visit 4. And I can estimate the link between visit 2 and visit 4, so that later, if I notice that a patient has visit 2 score of this, I've already estimated what that tends to mean, what the conditional distribution of their visit 4 is. Okay, so I'm able to impute patients that aren't complete based on the multiple imputation model estimated from complete patients. And that's how it works in FACS. The longitudinal models are estimated based on the set of complete patients. Then I get to go through, and for every other set of patients, say the patients who have observed visit 1, visit 2, visit 3, but not visit 4, I impute the 12-month visit based on the first 3. Some models only use the most recent one. Some models only use all of them. There's different ways to do this imputation. Okay. There's another set of patients that have observed 3 and 6 months, but not 9 or 12. Now we impute 12-month data based on 3 and 6-month data. Similarly, we can do these patients where we impute their 12-month final endpoint based on just their 3-month value. Okay. And then there's the subset of patients that have been enrolled in the last 3 months, right? That's in our study, like 39 patients or something like that will have been enrolled in the last 3 months is the expectation. And those patients don't have any intermediate data. We don't have anything to update our conditional distribution on them. They can only really be naively imputed from like the dose estimate, say. If I say, oh, they were randomized to dose 2. So I do know something about them, but not very much, just what the dose they were randomized to. So if I were to impute them, I don't have intermediate data to do that. Okay, so this is what FACS is doing in the background. And it's not imputing once, right? I keep saying multiple imputation. I'm going to keep saying multiple imputation. So each of these patients gets a new imputed value thousands of times, right? That's the MCMC integrate over the uncertainty in their final outcome, right? This is not just plug in a value. That's what that patient is. We are truly integrating over the potential values of their final endpoint for all of these patients as we go. And so this is a big process happening in the background. And you'll notice when you start doing longitudinal modeling, your FACS probably slows down a little bit because we're adding things to integrate over into Berry. Okay, so that's the gist of it, right? For every patient, we're going to try to give them the best estimate we can of their final endpoint. But we have to tell FACS how to do that. So I'm jumping back to an updated FACS file. I took the existing one, the one we were just looking at that was really simple, and I just added, I clicked this button right here. I clicked this use longitudinal modeling. I say self-explanatory. It does quite a few things. It turns a bunch of stuff on. The most apparent thing is that I don't want to click the button because I have results saved, so I don't want them to delete. The most apparent thing that it does when you click this is that it creates this grid here. Instead of just having a time to final endpoint, now I have a visit schedule. So patients have a first visit at 13 weeks, which is about 3 months, then 26 weeks, 39 weeks, and 52 weeks. So those are 3, 6, 9, and 12 month visits that I've set up. Treatment arms are the same. Virtual subject response is the same in the sense that the dose response, like the efficacy scenarios I'm simulating, are identical to before, but the longitudinal tab has been created. Okay, this is a huge part of this, so I'm going to try to go slow and describe the theory behind this because it applies to all trials when you're simulating multiple visits, right? It's not just this specific case I'm showing you. This happens for dichotomous as well. It happens no matter what type of multiple imputation you want to do for continuous. You have to fill out this tab. There's 4 different methods here. I'm going to actually do something. I'm going to save this. I'm just going to save as temp so that I can edit stuff. There's 4 different models here. And like the dose response, I can create a bunch of different scenarios. So I've created 3. A no correlation, a weak correlation, and a strong correlation. Within a single longitudinal assumption, right? When we're in this VSR, these are trial assumptions of how the patients are to be simulated. When I'm simulating patients and trying to set this up, I have to choose some parameters, and I can choose different ways to characterize the dependence within a patient across visits. There's different models. The correlated model is basically like a multivariate normal with a constrained sort of correlation structure. You can think of hierarchical creates this change up to the final response and then allows jitter around that. Hierarchical MMRM is similar, just slightly different in how it moves the mean and the patient random effects around. And then ITP has its own parametric structure that allows you to get curves that sort of slope up at the end or slope up early or stay straight. And, it's sort of an opinionated model, but you can stare at this equation for long enough to kind of start understanding what K sub D does and what the subject random effect SI does and things like that. So again, this is what I would talk about for an hour if I had 8 hours, but I don't. So when I did this,
Sorry to interrupt. There's 2 questions. One I can read to you, and then for the other one, maybe we'll unmute Vlad to ask his question himself. So the first question is there any fine-tuning of the multiple imputation model needed during the simulation? And if yes, what sort of diagnostics does FACTS use? For example, WAIC.
Yeah, okay. I'm not familiar with WAIC. I imagine it's like AIC, but I'm guessing. But I can answer the other part of the question. Yeah, I did fine-tune this. For me, the fine-tuning was getting out a piece of paper and writing what I expected to happen, and then in my head, it was, okay, make up a value for 3 months. What do I think is going to happen at 12 months for a patient like that? Like, based on the trend I saw, this is the data from that phase 2 study. So you can see it's pretty linear going down. I took that into account. Like, it's not like a big drop and then a flatten. Like, it's pretty linear as time goes. The patients get better pretty constantly, or get worse pretty constantly throughout that course. So that's something I took into account. And so I set up my priors, which is how we do that tuning, that fine tuning for the longitudinal model. I set up my priors and I said, okay, I think that's right for the means. And then I set pretty wide standard deviations. And then it went to simulating. So I simulated that and I went in and I looked at the outcomes. I looked at the parameter estimates for the longitudinal models, which you can get from the simulations file in VAX. So I could look at what it estimated for my specific parameters. I looked at, which I'm going to show you, the standard error of the credible intervals and said, okay, did it actually improve my estimates? What about the means? Did it change my means? Did it pull things together too much? So yeah, I did do a lot of tuning, and that's something that I'll talk about actually as I go forward. And then Vlad's question,
I've unmuted Vlad, so there we go.
I think you can hear me, right?
yes.
Okay, Nick, when you explain about the multiple imputation that you use during the interim analysis in order to predict the final endpoint, then you claim at the end that at the end of the study, all observations on all subjects are there. You don't need any multiple imputation. And my question was, can you comment how FACS deals with missing data? In your example, you kind of said no missing data, no dropouts. But
Yeah.
is there any difference? How that is handled when you simulate with missing data?
Yeah. So if I had gone to this tab, the dropouts tab, and said, yeah, I actually want to simulate 20% dropouts per dose or something like that, I could have done that easily. Maybe that's realistic in Alzheimer's, and I want to include it in my simulations. Okay. Again, we're not talking about the case where there's patients that haven't had a year of follow-up yet. We've established that those patients are imputed. We're talking about patients who drop out and are lost to follow-up. There's multiple ways to handle them. That's specified at the bottom of the dose response tab. So there's this handle of missing data due to dropouts. The default is exactly what you'd expect based on what I've said. The default value is that I'm going to impute those patients based on my longitudinal model or based on what I have. And that's what this says. So do Bayesian multiple imputation from any visits that you have for that subject. The alternatives are the really simple versions, like the last observation carried forward. This is a single imputation. It's not varying. It's not integrating over uncertainty. It's just fixing the final value at the last observed value. So there's two ways that you can do that if you have missing this. You can either do last observation carried forward, or you can do multiple imputation from post-baseline. And if you want to ignore them completely, sort of an intricacy of FACS, if you tell it there's a longitudinal model, you have to use a longitudinal model. So if you want to ignore them completely, right now you have to tell it, oh, actually, there's no longitudinal model for these patients.
Yeah, but when you explain how the machinery is doing when you want to predict or do imputation for the final endpoint, you explain very nicely. You start with completers and you go down, down, down. Missing data might be that they had a missing data, but then they came back. So I was not clear how that missing data on, let's say, visit number 3, you are dealing.
Yeah. Okay. I see. So, yeah, FACS doesn't skip visits. So that, I think that's a simplifying thing. It's not possible for a patient to observe visit 1 and 2, not observe 3, but observe 4. Okay. So when you drop out, you're lost to follow up completely in FACS.
And you are imputing only the final endpoint for that.
Yeah.
Visit. Okay.
Yeah. We don't impute.
Sorry for taking time.
Yeah. No, I get it. Good question. Thanks. Okay. I'm going to go back. So I've set this up, the VSRs, and I've said I want high correlation. I've said I want moderate correlation, 0.7. So this is 3-month and 6-month have a 0.7 correlation. 6 and 9 have a 0.7 correlation, and 9 and 12 have a 0.7 correlation is what this is saying. You can read about this in the user guide or the tooltips if you want. So I have a weakish one, a strong correlation, and no correlation. So I set this as 0. I did other things like, I want you to go pretty linearly from 0 to 12 months as far as the observed response goes. And then I want the variance to get a little bit bigger as we go. Okay, so strong, weak, no correlation. And these are simulation assumptions, right? So I can plot the patients after this, look at this, make sure that they match what I assume. And then I go to the design tab and it's added this longitudinal models, this longitudinal tab. There are, in the continuous engine, really 4 multiple imputation models. The linear regression model, time course hierarchical, kernel density, and then this is the integrated 2-part model. I'm not going to go through all these in detail, but each of them have their own equations, have their own shapes and opinions about what the shape of the patient should be. We have interpretations here, and there's much more in the user guide. So I encourage you to kind of sit down with these and let them simmer, because looking at this right off the bat, it's not obvious. But when you start to say, okay, assume K is 0, what happens? well, this gets canceled out. This is zero. Yeah. And you start to realize, to discover what these models are saying. The linear regression model is the simplest of the multiple imputation models in my mind. It's really simple because it just says, given the most recent visit for a patient, I'm going to take some alpha plus beta times that visit to impute the final value. Okay, where alpha and beta are estimated from your completers. Okay, so given a 3-month visit, if I only have a 3-month visit, I'm going to take some intercept plus beta times my 3-month value, and that's my imputed value for 12 months. So it's really pretty independently estimating the relationship between 3 and 12, 6 and 12, and 9 and 12. I have set it up so that the priors, so the prior for the 3-month to 12-month prediction are different than the priors for the 6 to 12, and the priors, and those are different than the 9 to 12 predictions. Okay, I could go through these if I had a little more time, but basically this is what I said, where I wrote down, okay, what if the first value is this, then I expect this. What if the first value is this, then I expect this. Okay, so that's the imputation model I put together. I want to get to the efficiencies gained, so apologies for not discussing all these parameters in detail, but it's a pretty, intended to look simple. It's hard to understand, but it is, independent in the sense that each visit imputes the final visit on its own. Okay, so when I did this, I didn't change anything about allocations, interims, success futility. I tried to keep the type 1 error the same. And so I'll just minimize. When I did this, I want to know if we gained anything. So I simulated those. I simulated 1,000 trials in each of them, and then started looking at the interims, because I'm really interested in interim analysis efficiency. I said, that's where we gain efficiency, because that's where we have missingness. So I went and I dug in and I focused on that 4th interim analysis. 350 patients out of 800 enrolled, still not even halfway. At that point, we have 194 complete subjects in total. That's about 32 to 33 per arm. We also have 39 subjects between 9 and 12 months, 39 subjects between 6 and 9, and 39 subjects between 3 and 6. So another, 118 or something like that, 117 subjects with some intermediate data. And then there's 39 subjects on average at this interim that had no data. Okay, so these subjects are where I'm trying to gain efficiency. I'm trying to improve my estimate of the 12-month change from baseline in ADCOMs using the 3, 6, and 9-month visits. So I pulled numbers out, and I'm going to show you those numbers. I went into facts and I copy and pasted things. And this is what we get. So right now, I'm just showing you, again, remember that 0.032 from here, where I said I'm going to ground you in this number? Well, now I'm grounding you. So 0.032, that's the standard error of the dose response estimate if I don't use any longitudinal data. Okay, what if I do use longitudinal data? So I guess 0.032. In reality, when I simulated in facts, it was 0.0317 was the standard error of the estimate for control and the standard error of the estimate for the highest dose. That's the 0.032. So we're grounding now in 0.0317. When I used the longitudinal model, but I didn't actually simulate endpoint correlation, I got pretty moderate gains. And these are hallucinated for the most part, right? The model's finding gains where there aren't any. And so that's an interesting component, is that if by random chance you do have, a 0.3 correlation or something like that in your random sample, the longitudinal model is going to notice that, and it's going to think it's doing a good job of predicting. We think it's going to have enough uncertainty that it doesn't change stuff that much. And you see that the reduction here is not that dramatic, but the longitudinal model does reduce the standard error of that estimate. When we start adding endpoint correlation, we get bigger reductions, I guess. So when we have our longitudinal model with the weak endpoint, our standard errors go down. And when we have a longitudinal model with strong endpoint correlation, we go down even more. This is expected. The more your early visits are correlated with your final visit, the more helpful the longitudinal model is going to be. It's hard to tell what help means on this scale. So I think it's easier to tell on a different scale. So I've reported the effective sample size. So the sigma over the square root of n calculation. I've just back solved for n that would be necessary to get this sigma, or this S, I guess, the standard error, okay, to get the effective sample size. And so then we can compare, we can kind of calculate what is the longitudinal model doing for us in the context of how many patients it's adding to our estimation. If there were 32.2, based on this standard error, there were 32.2 patients going into that estimation with no longitudinal data. By the time we get to the strong endpoint correlation, we now have 44 patients influencing just the control arm. Okay, that's a 12-patient improvement on that one arm. We have 6 arms. The active arms have their own improvement. I should have said the control arm has one longitudinal model and the active arms all share another. So I did do these a little, that's why I separated them like this. That's the model I specified in facts. Okay, so we get 12-patient improvement. These are, effective patients gained by having the early data with variability. So the early patients are downweighted, but we don't know by how much. And this is an estimate of that improvement. On the treatment arms, we averaged 13.6 patient improvement over no longitudinal model in this case for all 5 arms, right? So multiply this by 5 and you get the actual total effective sample size for that treatment arm. You can see that when the endpoints are less correlated, you get smaller gains. And when they're uncorrelated, our hallucinated gains are smallish, but not 0. Okay, I'm going to keep adding to this context. Okay, so you can see the numbers go up, right? The effective sample size goes up, meaning we are getting pseudo patients, fake patients through this sort of longitudinal model. To add this up and say, okay, at the analysis at the 4th interim, what does that mean? There are 194 completers at that interim. So patients with 12-month data. If we naively just use that 12-month data, we get 194 patients. If we add a longitudinal model, we go up by almost 80 patients in effective sample size. Is what we improve by using this longitudinal model. Okay, so we went from 194 to 273 in terms of the contribution to the treatment effect. The best we ever could have done is 311. That's if the data was perfectly correlated, and if we knew 3 months, we automatically knew 12 months, we would have gotten 311. So we got more than halfway from no data to full data using that longitudinal model with a pretty strong correlation assumed between them. We got less than halfway using a weak correlation, but we still got 40% or something like that of the way there, which is not nothing. Okay, so I tried to frame the improvements in terms of patients gained or patients saved, if you will, in this case. And you can see that while there's 117 patients or something like that outstanding that are don't have full data, we get almost 80 patients worth of information out of those 117, which is nice. This is a number you can calculate on your own. If you pull out the standard error of the treatment estimates and you back solve that, you can calculate your own effective sample size, which I think is a really nice way to present these benefits. Okay, cool. We get benefits, we get statistical efficiencies, but we don't want to improve the precision of our estimates at interim 4. We want to improve the probability of declaring success if there is a benefit, or we want to reduce the sample size of the trial. So do our improvements in, precision of that dose estimate actually lead to gains in operating characteristics? The answer is yes. I should have broken this table up into parts. Let's focus on the null case. Okay, so I had to make this an apples to apples comparison. So what I tried to do is equalize the type 1 errors and equalize the powers of the no longitudinal data model. So this is the naive model that only uses completers. And then I have the longitudinal model with varying underlying true correlations within patients, right? We know that strong correlation is good for the longitudinal model. We like that better. It helps estimate, helps us impute. Okay, so I got the type 1 errors to be pretty similar, all right around 0.08. You can see that the sample size, and I should have described, so the top number is the power, or type 1 error in the null case, and the bottom number is the average sample size. The average sample sizes differ. And throughout this whole table, the powers are pretty similar across the board by default, by design, I mean, in each of these. So we can even go to the all doses are great scenario. We really have around 93% power for all of these. What really changes is the sample size. So we know that you get a trade-off. You can either have lower sample size or you can have higher power, and you can get any combination of those two. They're really the same statistical improvements. You just take them in different ways, whichever way you want. Okay, so in this case, I chose to take the benefits, the improvements in terms of sample size. And so when you're looking at this, you can see that the no longitudinal data use 535 patients on average to get 93% power. There's a spectrum here, but if we go to the correlation is strong within patients, we reduce this by 35 plus 35, about 70, 69, 70 patients. Okay, so we saved 70 patients by using this multiple imputation in that case. And again, it's not exactly like this, but I'm kind of using the same language I was using with sample size improvement is the idea. So we can save about 70 patients here. In other scenarios, like the good scenario, it's more modest. We only save 42 patients with about the same power. If all doses are kind of moderate, we're in that 65% power range. And interestingly, which this is something I might want to tune even more, if the doses are not very effective, like in the null case, or the all doses are okay, this is like a 20% benefit, which is not clinically significant. The sample size is actually smaller for non-correlated data, which is not expected. But what's happening is that futility rule I set is being hit much less by the strong correlation when we have strong correlation within an endpoint. So there's an interesting interaction here that I didn't fully explore and can't really fully explore on this call of the futility rule with the probability of clinically significant difference and the imputation. I think what I would do if I was looking at this, like, I don't like that, is create a predictive probability. And that's something I haven't talked about at all today, but predictive probabilities get a big boost from longitudinal models as well. So if I was to go into facts, I can go here, back to this template, and I can edit quantities of interest. I can create a predictive probability that we win the current trial, and it will impute patients using this multiple imputation model if we have data on them. And we can get a nice predictive probability using all the information, including the 3-month and 6-month visits that we've observed on these patients that aren't done yet. Okay, so a good futility rule might have been to incorporate a predictive probability into this to calculate futility. Something I didn't do for this example, but probably exactly what I would try if I was trying to fix this pattern that I thought was kind of non-intuitive. But these patterns hold largely throughout all of these rows. So generally, if the power is above 50%, the longitudinal model gives us the most benefit when there's strong correlation, gives us less benefit when there's weak correlation. And it does give us a reduction in sample size. But this is one of those things where if you truly believe that the data is uncorrelated, if this is a likely outcome where the 3-month visit has 0 correlation with the 12-month visit, a longitudinal model doesn't make a lot of sense. If you truly think they're uncorrelated, then any link that you find between them is not real, which you don't want to be modeling it if you know for a fact it's not real. But you probably also don't want to be collecting that data. So I don't know if this is a realistic scenario in most clinical trials, completely uncorrelated, but it's an interesting edge case to examine. Okay, so we showed that we gain efficiency in the actual analysis. This is the Bayesian model has smaller credible intervals with longitudinal modeling. That leads to either power gains or sample size reductions. You could have reworked some things to get power gains here. That is what we always say, like, oh, model longitudinally and you get improvements. There's not a lot of ways to take a clinical trial and gain power without adding patients to the trial, right? You can add adaptations and like a group sequential or Goldilocks design. You're going to get more power than if you ran a fixed trial with the same average sample size. But beyond that, I mean, it's hard to change your power curve. Using longitudinal data is a way to change your power curve. It's a way to improve power without increasing sample size, without adding, a bunch of interims and features or increasing type 1 error, anything like that. So it can be very useful in those cases. I think it's underused. These things make so much sense, right? You tell someone, oh no, I want you to completely ignore the first 3 visits for patients. Like that, it feels bad, if nothing else, to just completely ignore that data. And so using a longitudinal imputation model can help kind of bridge the gap between the naive, only use complete patients and have perfect information on all subjects. Okay, thanks for listening. I don't know if we have more questions. I'm at the hour, so I don't want to hold people on, but I am available to answer questions for a few more minutes if people would like. So again, thank you for listening. Let me know if you have questions. Okay, let's see.
I've allowed David to speak, so
Okay,
he should be
great.
able to ask his question.
We can't hear you, unfortunately. You did go unmuted, but we can't hear you still.
Maybe we'll come back to David and let's get Vlad's question.
Well, okay, Nick, thank you very much for the great presentation. So can you briefly comment about, let's say, if regulators insist on controlling type 1 error, when you will do longitudinal modeling in the design, of course, you showed us the simulations and you said that you fine-tune the critical values at interim and at the final for posterior, and you control it. But the type 1 error will be, or that kind of control of probability of wrong decisions will be also impacted by the longitudinal model that you will be using, right, in the simulation. Can you comment how tough it is to go through simulation scenarios now on the longitudinal models to see what will be the impact on the probability of type 1 error?
Yeah. So I've done this, and it can be challenging because, especially in a phase 3 setting where you want strict control, maybe you want strict type 0.025 control. The generally, so you'll notice patterns as you go through and specify no correlation, weak correlation, strong correlation. You'll start to notice patterns. And in general, this no correlation scenario is going to be your worst type 1 error, your highest, your hardest to control. So if you really want strict type 1 error control, I start with the edge cases. And I say, okay, if I control type 1 error in the edge cases where I have really strong and really weak type 1 error, and I can show that there's a clear pattern as I change the correlations, I feel like that is very descriptive and convincing in terms of, yeah, I am controlling type 1 error. Even though it's just through simulations, I'm controlling type 1 error. What I'll also say is that when I simulated this trial, where I did use longitudinal modeling, I got a type 1 error of 8%, the one that I showed. Then I went and I simulated the exact same trial, but I removed early data. I removed the longitudinal model. I simulated this trial and I got 12.3% type 1 error or something. So using no longitudinal model increased my type 1 error with the exact same settings. Obviously, the boundaries react differently, right? So these thresholds mean something slightly different when I'm not doing imputation, and the Bayesian models, tails cross these boundaries at slightly different times. So I actually noticed an increase in type 1 error when I took away the longitudinal model. I'm not going to claim that that's always the case, but it is, it dramatically increased in this situation when I did this simulation. So yeah, I try to create a pattern. I create a grid of accrual rates because that influences a lot, right? If you have fast accrual, you have more missingness. If you have slow accrual, you have less missingness. So I create a slow, expected, and a fast accrual rate. And then I vary the correlation of my simulated patients, early visits to late visits. And you can almost always see the pattern. And then you just have to decide if you want every single possible combination you simulated to be controlled below 0.025. Then you have to, do that work, and you have to get the slow correlation, slow accrual mixed with no correlation between endpoints to be below 0.025. And you very well may have 0.01 type 1 error in the expected case. And so that's what I always found challenging about this, was that I expect, and I'm pretty sure I know what the accrual rate's going to be. I'm pretty sure I know what the correlation's going to be. I control type 1 error in that case. Do I also have to control type 1 error in this is not possible in the trial case, but it is statistically, simulatable. And so that's a battle I've fought a couple of times through that sort of.
But I think that the debate usually is, I don't know if you can still hear me, but the debate with regulators is, yes, I don't want you to control in unrealistic scenario, right? Because for Bayesian design, you cannot guarantee that you control always type 1 error in the whole null space. But the argument sometimes is coming, show me that you control type 1 error in the most aggressive scenario, in a sense, and then they will be satisfied. But then it comes a question about the efficiency. If I guarantee through the simulation with the design in the most aggressive to be, let's say, the critical value should be not 988, but should be 999, the question will be, what if I do now a design which doesn't have this longitudinal modeling, but it controls even with a smaller critical value? So you see that then there is a different sort of comparison, head-to-head comparison of these designs. So I don't know if you had experience in order to have this sort of negotiation about, yes, I add this, but because I will be forced to control type 1 error very strictly, I will have to pay even more if I will rely on other method, which is not so restrictive, but then is not so efficient. And maybe they'll come close to each other.
Yeah. I think that's a good question. And there's so many different things moving at the same time, right? So it's not like I can say, yeah, this happens, this is the pattern. But what I will say is that we showed that we get efficiencies from longitudinal models. Like, it's not, I didn't, characterize it perfectly in every scenario, maybe, but we know in general, if you use more data, you're going to get efficiencies. But what you described is a situation where I'm actually having to over control type 1 error in a relevant case or something like that. And so now I'm comparing a design that's slightly more efficient, but has a smaller alpha, if you will. I mean, I air quoted alpha, with a design that's maybe less statistically efficient, but gets a bigger alpha. And you can bridge the gap in that. My intuition and my expectation, maybe this is like, naive adaptive trials all the time philosophy, but I still think you're going to get the benefits. And if you don't get the benefits, then I think I'd be surprised if you're not still getting a slight improvement by using the longitudinal model. But again, I don't know how bad the worst case that you're simulating is. And if you're not simulating a worst case for the using complete patients only scenario, which I know that looks a lot different. It's much simpler, but yeah, in my experience, you're still going to get gains. There are certainly times where it's like, I'm saving 13 patients. It's not worth doing all this for 13 patients in this one scenario, right? So you have to decide if it's worth the cost of the gains, but maybe characterizing gains like this and saying, this is how many patients I save, or this is the improvement in effective sample size, can help make that cost benefit analysis of what's not, this is not easy to do if you're going to implement a Bayesian design with a multiple imputation. I mean, it takes work. And so maybe that's not worth it in that context.
Thank you very much, Nick.
But yeah, I don't think I have a perfect answer to your question. But
the question is very complicated.
I know. And yeah, and simulate it over and over and over and get tables like this and then look at what happens in all these different scenarios. So that's my answer, is just keep simulating and comparing. And then once you have your information, you can make an informed decision. But vary your scenarios, vary your accrual rates, really learn the design is important. You can't make adaptive trials work if you don't learn the design, if you don't know its patterns and things like that throughout it. And so that's what I'll say, is just learn your design, simulate it over and over and over and over and over. Okay, David, do we have you?
Yeah, can you hear me now?
Yes.
Okay, so, thank you for the presentation. This is super helpful. So my question is, so here in this example, we looked at the continuous endpoint, which I know is standard in Alzheimer's disease. If we're working in a different therapeutic area where there's normally binary or time to event endpoints, is there anything we can do, or does this not apply?
Yes, there is stuff you can do. I'm going to pull up the core dichotomous engine, which I'm pulling up dichotomous because it is very similar to continuous in the sense that there's a longitudinal model here that you simulate patients with some, well, I didn't set up a scenario. So you can simulate patients. Actually, in this, it's like a discrete Markov chain where you go from responder to non-responder throughout your visits. And that's what this is allowing you to set up with, this equation describing it. And then there are fewer dose response models. So fewer longitudinal models. You can't do what we just described exactly like we did it, but you can do an imputation model with the beta binomial, where it's going to take an early visit and it's going to impute the final visit from a beta binomial distribution that it learns. Or you can do a logistic regression, which is really, really similar to what we just did. So for dichotomous, it's very similar, the ways you do this. It's essentially identical in terms of like the intuition and the understanding and the imputation mixed with the dose response model. That's all the exact same. Time to event is a beast. We could do 8 hours just on time to event. I can pull up really fast. The time to event, we talk about it a little differently. So you can specify a visit schedule in time to event, but that's not the same really. That's more of a censoring thing. What we do in time to event is we create a predictor. This is an endpoint that can be continuous, dichotomous, or time to event itself. We create an endpoint that is observed at a specific time, or for continuous dichotomous. And for time to event, you specify, it's doing a bunch of calculations as I click around. Yeah. Time to event, you specify a hazard rate for this endpoint, or you get a continuous dichotomous. So these are endpoints that are observed presumably before the actual primary endpoint, not always, but and what happens is once you have observed this amount of data, it will change how it's imputing your survival time. So it's not doing a longitudinal model in exactly the same sense. It's more of like, if you have an observed predictor, we have a little bit more information. So I'm going to change how I impute your survival time as I do this. And so you can do it in time to event, but if you just kind of use the intuition from continuous dichotomous, it's going to look a little different in there.
That's super cool. So in oncology, there might be like progression and using it to predict.
Yeah, absolutely. You'd set up a time to event. If you want PFS to be a predictor for overall survival, you could set up a time to event PFS. Events indicate failure, and then you specify things like the hazard rate given the predictor. So if you observe an early PFS, now we have an assumption of what overall survival is going to look like. And you can also do it the other way. So I know overall survival has this hazard rate, and the predictor distribution given that looks like this. And then in design, you set up a predictor model with some parametric or some relationship to that final endpoint. Sorry.
Oh, wow. That's so cool. Thank you.
Yeah, I'd point you towards the documentation for more information. docs.berryconsultants.com is our new documentation site. It's much more pleasant than some of the Word documents that we had before. So hopefully you can find what you need there. But yeah, we could do a whole, 4 hours about time to event prediction because there's a lot there and a lot of distributions. But good question. Thank you for asking.
Thank you.
All right. I don't know if we have more questions, but I feel like we need to wrap up, even though I could do this all day. So again, thank you for staying late. Thank you for listening. We will see you next time on FACS webinars.